Friday, June 20th. We're going to go ahead and get started. Dr. Khan, I'll hand it over to you.
Good morning, everybody. This is Dr. Ikram Khan for the Patient Protection Commission. Can we go ahead with the roll call, please, Joseph?
Sure. Thank you. This is Joseph Filippi for the record. I'm going to first start by calling out the voting commission members' names. When you hear your name, please let us know if you're present this morning. Starting with Miss Marilyn Kirkpatrick.
Here.
Thank you. Dr. Bio Curry Wenchel. I just remembered she was going to be absent, excused today, so we'll mark her absent. Dr. Mark Glyman.
Here.
Thank you. Dr. Adam Parath.
Here.
And forgive me, Adam, is it Parath or Porth? I want to make sure I'm getting that right.
Porth is correct.
Porth. Thank you.
Yeah.
Miss Bethany Sexton said she was going to be absent today. Mr. Walter Davis.
Here.
Thank you. Dr. Andrea Peterson.
Here.
Thank you. And then Miss Florine Kahn said she was going to be a little late this morning. So Maybelline, if you can help mark her present when she arrives. And then Miss Jalen Bahunin, are you here? Dr. Travis Walker.
Here.
Thank you. And Chair Khan.
Present.
Perfect. Dr. Khan, we do have quorum. Before we get started, I just want to make sure we have the non-voting members as well, starting with Insurance Commissioner Scott Kipper or his designee.
Here.
Perfect. Thank you, Mr. Kipper. I believe we have Deputy Director Shannon Litz on behalf of Richard Whitley.
Here.
Thank you. And Executive Officer Glover.
Here.
Thank you. And I believe we have Miss Davis on behalf of Executive Director Russell Cook from the Silver State Health Insurance Exchange.
Yes, present.
Thank you. All right, perfect. Dr. Khan, we do have quorum and can move forward. Thank you.
Thank you. So the next item on the agenda is public comment. Ed, you want, can you take on?
Thanks, Dr. Khan. So for item number 2, public comment, if you're joining by phone today, just for everyone's awareness, the phone number is 775-321-6111. When prompted for the meeting ID, please press 945-259-107#. And if you're joining by phone, you can press *5 to raise your hand and we'll call upon you. If you're joining by Teams or by the computer, just hit the raised hand feature at the top of your screen. And not seeing any requests for public comment this morning, Dr. Khan.
All right, thank you. So we move ahead. The next item on the agenda is some good news. We have our new commissioner appointed, Dr. Travis Walker. We're excited to have you join. Dr. Walker, would you like to make some comments for us?
No, I just want to say thank you, and I appreciate the support that I've received up to this point, and very excited to get going. I think Joseph sent in my bio, and I don't want to reiterate or recite it, but just appreciate being here, and I'll be on camera next time.
Thanks, Dr. Walker. And just for awareness for the public, do you mind just giving just a brief background? I know that you shared your bio, and I did share that with members, but just for the public, if you don't mind just giving a little bit of background on yourself and the position you're filling on the commission.
Absolutely. I'm a family-trained physician. Grew up in Reno, attended UNR and the University of Nevada School of Medicine. I'm currently serving as the Chief Medical Officer for Community Health Alliance, and I serve as the FQHC physician representative for this commission.
Perfect. Thank you so much for sharing.
Thank you very much. Our next item on the agenda is for a possible action. It's actually action, review and approve meeting minutes from March 14, 2025. So I would need, these minutes were sent to everybody. As I recall, I got a copy. If everybody has had a chance to review them, then I would ask for Motion
Motion.
to approve. Second?
Walter, second.
Second. Any opposed? Here, see none, so the minutes are approved. Next item on the agenda is for possible action. Commission to recognize the implementation of AB 7, 2023 and regulations LCB file number R173-24 as meeting the requirements of NRS 439.9181C. So, Ed, we want to elaborate on this, please?
Yes, Dr. Khan, this is Joseph Filippi for the record again. So the item before the commission this morning, we actually started this conversation back in January of this year, where Nevada Medicaid actually gave a comprehensive presentation during that meeting. And I did share the slide deck once again with you all. But the presentation was regarding Assembly Bill 7 from the 2023 legislative session, which is actually a bill that the Patient Protection Commission brought forward back then. And that bill passed, and it required the Department of Health and Human Services to establish a regulation that would help create, that would basically create a requirement for healthcare providers to implement interoperable electronic health record systems or health information exchanges to allow patients electronic access to their medical records. And so the department throughout 2024, they worked on those regulations. They had an advisory group established that was convened throughout the year, and the advisory group helped develop the regulations that were eventually approved by the department director and also by the legislative commission. And so the regulations, they were adopted in December of last year by the legislature, and they became law effectively then. And those regulations are known as LCB file number 173-24. That was also shared with members ahead of this meeting, and it's also posted on our public website as well as a meeting attachment. But those regulations overall, they emphasize flexible options for healthcare providers to come into compliance with this law. They require that patients have direct access to their medical records, and they also align with federal laws and regulations. And so when I first took this position, I was reviewing the statute that lists the requirements of the commission. Among that statute in NRS 439.9181C, it requires the commission to develop a plan and then annually update a plan to help increase access to patients' medical records. And so seeing the similarities between these regulations and that statute that was originally created back in 21, I thought I'd bring this item before you all for consideration to really recognize the regulations that were developed by the department and various stakeholders and that have been approved now by the legislature, and really recognizing those regulations as meeting the same intent of the the NRS that requires you all to create that healthcare access plan, which would really no longer justify the need for the Patient Protection Commission to develop and annually update a plan. And so as the slide before you shows, you have a decision today to really recognize these regulations as meeting that intent and not creating a plan going forward, or you could continue to work on developing a plan and annually update that plan related to increasing access to patients' medical records. And really how the statute is written, it requires us to create a plan and then submit that to the department director annually. And so, and just for transparency, that plan has not been developed thus far. Work was being done back in 2022 to create that plan, but it was never finalized. So this is the item before you. The decisions are here on the screen. With that, I'll go ahead and hand it back over to you and Chair Khan.
Thank you, Joseph. So this was passed on in the materials that were sent by Joseph to all the commissioners, and I hope everybody has had an opportunity to review them. If that is the case, or if somebody has not had a chance to review them, may certainly review them. But having said that, is there any further discussion, or is everybody seems to be in agreement with what Joseph alluded to, is do we endorse that, or we want to create a plan of our own, given the explanation from Joseph? So I'll open it up for any comments from the commissioners.
Marilyn, please go ahead.
Can I just ask for a point of clarification, because it seems like they somewhat contradict themselves, but do we not want a plan on the state level that shows up? Because things are constantly changing across the country, federally and on the state, but I just worry that if we don't have a plan with so many new legislators coming in all the time, that they may try to create their own, which make me nervous. I mean, so I just am trying to understand our options.
Joseph, you want to address that?
Sure, I'll try. So Marilyn, I would just say that I think one of the difficulties of creating the plan back in 2022 was the fact that federal regulations are constantly evolving and changing. And so, we can, when creating a plan, you almost have to update it, I would say monthly or quarterly at least. And so I think that the point of these regulations that were passed are basically just, they're already in compliance with existing HIPAA laws and other regulations. And I believe the way that the regulations are framed, it would just, healthcare providers would have to continually stay up to date on what those current federal HIPAA and regulations are to be in compliance with these interoperability requirements. I know we have a representative from Nevada Medicaid who helped develop these regulations if we want to go into that a little bit deeper. But I see a couple of hands raised. So Adam, go ahead, and Gabe from the Deputy Attorney General's office, please go ahead.
Yeah, Adam Porth for the record. I would agree, Joseph. I feel like the regulation was crafted pretty well to allow an on-ramp for different provider types to comply with this. And it was written in a way that provides some flexibility around what the laws are today and what they may be in the future.
Thank you for that.
Thank you. AG's office?
Yeah, this is Gabriel Leifert. I just wanted to add, in addressing Commissioner Kirkpatrick's concern, is there an opportunity, Joseph, for this commission to re-examine this in the future? I know the law originally talked about updating it annually. Assuming they were to vote on this, what will the plans be to perhaps ever bring this back? Certainly, if the chair were to ask you, or if you saw there was an issue, you would bring it back. Other than that, are there other ways that perhaps this might be re-examined if there are some changes or something comes up where this commission might want to look at this again in the future?
Yeah, thank you, Joseph Philippi, for the record. I think that's well within the scope of the commission. You're tasked with constantly reviewing regulations and laws that have been passed or that are being proposed. So if there's something that's changed at the federal level or even the state level that would impact patient access to their medical records, that's something within your scope to review. And if there is a need to bring that before, the department or even the legislature, the governor, we are well able to do that. So agree with the AG's office that, if we recognize these regulations as meeting the intent as it stands today, but if there's ever any concerns that we become aware of in the future, we're able to review any issues and provide recommendations.
Any other comments before I give my opinion?
Dr. Peterson, please go ahead.
Yeah, I was going to say, I think that there could lead to some confusion by having the two different plans. I think I do kind of like having that annual evaluation on, are there any changes with, that need to be made with the DHHS plan, if that could be possible.
All right, thank you. Anyone else?
Yeah, I have.
Yes, go ahead.
So how is this different than from the 83rd Legislature Bill 398, the Senate bill that was approved and then the governor vetoed? Because in that bill, there was a significant amount of regulation so that patients could get access to their records from offices and providers. And I think the failure in that part was the rider that was attached that would have affected all the freestanding emergency rooms. And I think that's part of the reason it failed. So can you just delineate how that diverges from where we're at now?
I can try to start that, and maybe I might pass that on to Dr. Southard with Medicaid. So I believe you're referring to SB 378, and this is
Yep.
Joseph Philippi for the record again. It
That's correct.
would have changed the requirement that these regulations apply to all healthcare provider types. It would have reduced that to only a certain few types of provider types would have to comply with this, is my understanding. And so these regulations that are currently before you, if that bill were to have passed, would have likely had to been revised to then be in compliance with that bill's changes. But as you stated, the governor did veto that bill. So these regulations still stand as they were approved back in December. Melinda, do you want to say anything further in case I misspoke anywhere?
Oh, sure. Thanks, Joseph. Melinda Southard for the record with Nevada Medicaid. Just one addition. So SB 78 also would have required us to remove the option for providers to be able to utilize the health information exchange as being in compliance with the law. So again, that was vetoed. So everything is as is today, and you're correct. It adheres to a very large population of healthcare providers and medical facilities, including EMS.
Thank you. Any other comments? If not, my personal opinion is that these regulations were fairly comprehensive at that time and pretty heavily discussed and debated. Having said that, as alluded to earlier by several of you and Joseph, that the commission has the option going forward if they need to address issues coming up and make recommendations. My concern is that if we don't have a basis to start with, like these regulations, which I think were pretty good, Medicaid changes, as you all know, are in a flux right now from the feds. We don't know where things are going, what will be mandated, not mandated. So we will have to keep reviewing them on a regular basis. So it doesn't take away our option to keep reevaluating as things evolve over the next year and beyond. So personally, I think these regulations were pretty comprehensive at that time. And if changes need to be made and we become aware of them, then we can certainly discuss and debate at that time and make our recommendations. Any other comments? If not, I think this is an action item, right, Joseph?
Yes, it is, Dr. Khan.
Yeah, so I think we need an approval if everybody agrees with this position. So I would need a motion. The first question is to approve these regulations as is, with the option of addressing them in the future with new developments.
Motion.
Second, anybody second? All right, any opposed? All right, so the motion carries. Thank you very much. Our next item on the agenda is again informational. This is again Joseph, 83rd Legislative Session update. Joseph, you might take 2 days to give us this update from the legislature.
This is Joseph Philippi for the record. Thanks, Dr. Khan. No, so I'm actually going to do a very short update for you all today. There is a larger, more comprehensive update in the draft PPC report that's been submitted for your review today as well. Really, there was, as you all know, hundreds of bills introduced and actually passed this session related to healthcare. So did not do a comprehensive overview of every single bill, but wanted to highlight a few bills that relate to some of the recommendations and discussions that you've all had within the last year or so. So as you all know, unfortunately, the 3 bills that we proposed to the session this last year, SB 29, 34, and 40, they did not end up passing. They were among the bills that failed to meet the first committee deadline on April 11th. Although these bills failed to pass, though, several other pieces of legislation were enacted and signed by the governor that also meet similar legislative intent to the recommendations that you brought forward. Specifically, some of that intent is to simplify the licensure process for healthcare professionals, reduce provider administrative burdens, and provide state investments for workforce and GME. So some bills that did end up passing on this first bullet here related to interstate licensure compact, similar to what you recommended. These three bills, AB 163 actually enters Nevada into the counseling compact. AB 230 enters Nevada into one of the compacts you all proposed, which is the audiology and speech language pathology compact. And then AB 248 is another compact you proposed, which would enter Nevada into the physical therapy compact. So I see this as a success. Really, our bill, SB 34, was proposing 5 different compacts for the state to join, and it looks like we joined 2 out of the 5. So I see that as a win, even though it was not through our piece of legislation. Moving on to the second bullet here related to the physician workforce, SB 124 was signed by the governor, and that will increase the physician workforce pipeline by providing a pathway for physicians who graduated from a foreign medical school and trained in other countries to hold a limited license to practice medicine in Nevada. These providers would, with this limited license, would still be under the supervision of a licensed physician and be able to practice in certain facility types and settings. Once the holder of a limited license has completed 2 years of practice in the state, the Board of Medical Examiners is then required to issue an unrestricted license to this provider. So I believe during the testimony during the bill hearing, the bill sponsor indicated there was approximately 70 foreign medical doctors in the Las Vegas area in Clark County that would be able to qualify for these limited licenses. So I believe, now that this bill is passed and once, the Board of Medical Examiners passes any necessary regulations, there's the potential for at least 70 providers in the Clark County area to immediately start practicing, which is pretty exciting. And I'm sure this will have other access opportunities throughout the state, including in rural areas. Related to graduate medical education, SB 262 transfers the existing GME grant program and advisory council from the Office of Science, Innovation, and Technology and it moves it under the new Nevada Health Authority, which I'll get into that in a moment, what that is. But the bill also provides a $9 million appropriation for graduate medical education grants, and they aim to help fund residency programs and promote the expansion and sustainability of the programs in the state. There was specific language added to the bill, which requires, as you know, there's been existing GME programs in the state that have actually closed eventually due to lack of funding. And so it creates additional oversight of GME programs in the state to basically have existing GME programs notify the department when they are planning to either close or reduce services and reduce the number of residencies that they have. So I think this bill provides not only more funding towards GME, but it provides the department with greater oversight on what the needs are of the existing programs in order to hopefully support them to continue, but also to help them expand.
All right, thank you. Next.
Last slide here, and then I'll stop with this legislative update. But SB 494 restructures the Department of Health and Human Services. It splits it into 2 new organizations. One would be the Department of Human Services. That will be led by the existing director, Richard Whitley. And then it will create a second department, the Nevada Health Authority, and that's going to be led by Director Stacy Weeks, who's the current administrator over Nevada Medicaid. The Nevada Health Authority specifically is meant to serve as the state's payer, purchaser, and policymaker for the delivery of healthcare, with the core goal of ensuring covered Nevadans, which also includes state employees, have timely access to affordable health insurance and quality care. So along with Nevada Medicaid moving under this health authority, the Silver State Health Insurance Exchange is also moving under, and the Public Employee Benefits Program, State Employee Health Insurance, is moving under the umbrella as well. So under this new health authority, it will provide healthcare coverage to 1 in every 3 Nevadans, approximately 1 million recipients statewide, which will help the state better maximize public dollars and ultimately lower the cost of healthcare for the state by consolidating resources. In relation to the Patient Protection Commission specifically, the bill does move the commission from the Department of Health and Human Services Director's Office into a new Consumer Health Division within the Nevada Health Authority. The PPC members and the executive director are now appointed by the Health Authority Director rather than just the governor, but these appointments are still subject to approval from the governor as well. And so, as I mentioned earlier, there's a more comprehensive legislative update in the PPC's draft report that was submitted for your review today. And then I've also asked Director Stacy Weeks to provide a formal update regarding the implementation of the bill and also the vision of the health authority during our next PPC meeting in August. So look forward to hearing more from her then. With that, Dr. Khan, I'll go ahead and conclude my short summary today and open up for any questions that you might have.
Thank you, Joseph. That was a nice, concise summary. So open up for discussion. Any commissioners have any comments on this presentation?
Mr. Davis, go ahead.
Yeah, hi, thanks for the record, Commissioner Davis. Going back to the provider workforce, and my first question is, how will organizations be notified of these available providers? And then secondly, I believe there is a limit to how many one provider can supervise these individuals, and therefore there might be a cost associated with that for incentivizing our providers to supervise those individuals. And I just wanted to make sure of those things were taken into account as we look at, I believe you said it was about approximately 70 that might be available in Nevada. And if that is the case, based on some of these limitations, how many could we really plan to accept?
I might have to take those questions offline, Mr. Davis, and get back to you. I believe the bill included language where these limited license providers would also, in order to receive that limited license, have to provide a letter from an employer in the state, basically to show that they've already applied for an opening with a facility and that they're, pending employment, that helps them be eligible for this limited license. So I might need to get back to you related to the supervision piece and how the board's going to ensure that. But yeah, happy to get those answers to you offline and share it with the rest of the commission as well.
So these are established by the relevant medical boards, the guidance and regulations of supervision. They have already in the past and currently in existence established supervision requirements, good or bad or otherwise, for PAs. They established the supervision, etc., requirements for people, the international medical graduates on a J1 visa. So they've established the oversight requirements for them. So I expect this to come with specifics from the respective boards.
Yeah, I believe the requirements right now is that the supervision is up to 3. And if you have to send a letter in to get any extension of that to supervise more than 3. I believe that's the current expectations and responsibility.
Yeah, you're right. The challenge I believe the boards have struggled with in the past, when these physicians are working in physician offices, for example, and there are 3 physicians in one office, how really closely can the physician, quote unquote, oversee their function as one person? Whether it's burdensome for the individual physician to see 3 or oversee 3, and if you increase the number, whether that is practically speaking, a good thing to do or not. So that's the area that they are working on, as I understand. We can get more information by sending a direct inquiry to them so that they can let us know officially what they have done or planning to do.
And Marilyn, you have your hand up. Please go ahead.
I just wanted to say, I think that, Joseph, you guys did a good job. I think by Director Weeks getting that separation is going to be super helpful. I think there's an opportunity. As you all know, the governor's bill even didn't make it. So these are all starting points, and I think there's an opportunity within this early part of the fiscal year to get some additional dollars for graduate medical education. I think that that will come about. So I know that it costs. So the whole goal was to put as much money there so we could build a long-term sustainability. So I would just say that we should just keep our ear close to the ground, because with all of the federal changes coming, there's an opportunity for Nevada to come in behind and kind of clean some of that up. But I think you guys did a great job, Joseph. And I'm trying to already work on the staffing ratio thing, trying to figure out how to fix that. So
thank you.
That was among the bills that was vetoed as well, correct, Marilyn? The staffing ratio.
oops. Yes, that was. So, I mean, I think we've moved some mountains on things, whether our name's on it or not. Listen, I always say that credit is the best credit you get is when someone steals your idea and puts their name on it. So I think that's what happened to the Patient Protection Board bills.
Thank you, Commissioner Kilpatrick. Any other comments before we move to the next item? I don't see or hear any. Do you, Joseph?
No, Dr. Khan, I do not.
All right, so we move to our next item for possible action. Discuss PPC policy focus areas and the development of subcommittees. So we've allocated 30 minutes to this. Joseph, you want to take it from here?
Sure. Thank you, Dr. Khan. Joseph Philippi for the record again. This is a little bit longer of a presentation, so bear with me here. Just wanted to make sure we have a lot of information shared with you so that you can make good decisions related to these subcommittees this morning. So just quick overview. As you know, the governor's healthcare policy priorities. There's many priorities, specifically in his 3-year plan listed here and in the executive order related to the PPC released last year. It asked the state to address the healthcare workforce challenges and access to care needs within the state, including improving access to care, expanding Medicaid payment quality outcome incentives, and supporting the build out of the healthcare infrastructure in the state. The PPC's priority areas, we sent out a survey earlier this year to you all for feedback related to what are some areas that you think, as we know, there's many needs in the state, but what are some priority focus areas that you all would like the commission to focus on over the next interim? On the right-hand side of this slide here, primary care, behavioral health, women's health, and healthcare workforce were identified as the top areas based upon the survey results. And so as shared with you over email, behavioral health was definitely a high priority area identified by you all. There's many entities and boards focusing on behavioral health care needs in the state currently. And so rather than creating a standalone subcommittee from the PPC, it's my opinion that the commission could achieve better impact by integrating behavioral health interventions into other policy focus areas, such as when we're looking at primary care and other needs. As you know, the state ranks low on many indicators on the left-hand side of this slide. Some of those indicators are listed. For sake of time, I won't go over that. But just for awareness, the PPC is eligible to create subcommittees or work groups per statute. NRS 439.912 specifically allows the commission to establish subcommittees and work groups that can consist of members of the commission or other persons. So I just wanted to highlight that. to assist the commission in the performance of its duties. It's also written in statute that these subcommittees are really temporary. They're meant to expire 6 months after they're created. But if there is a need, the commission can vote to continue those subcommittees beyond that 6-month time frame. On the right-hand side of this slide, just wanted to highlight the expectations of these subcommittees if we were to develop any. Each of them would be responsible for reviewing certain priority areas as requested by you as the larger commission. Members of these subcommittees would serve as subject matter experts and advisors to the larger commission, but would not have the same voting rights as you as the larger commission. So they couldn't really submit BDR requests or formal recommendations. They would really just be advisors to you all to then where you as the larger PPC can then decide if you want to adopt any of their recommendations, to include them in your final recommendations and or bill draft requests. And so just wanted to note that as primary care and women's health were among the top 4 areas, those are going to be discussed today for possible subcommittees to create. And so first, starting with primary care, I want to go over just really quick the need. So as you all know, healthcare spending in the nation, we're nearly 2 times more. We spend more than comparable countries do, and yet we have worse health outcomes. Among the nation, Nevada has the highest average annual healthcare expenditure growth. According to this statistic, we rank the highest in healthcare expenses, but as you know, we rank among the lowest in the nation when it comes to healthcare quality and other metrics. So health outcomes in the nation, in the U.S., our life expectancy is lower than most developed nations who spend much less on healthcare, and the rates of uncontrolled chronic disease is rising in the U.S. Related to primary care specifically, as you all know, primary care, when achieving its full potential, has the capacity to enhance life expectancy, improve health outcomes, and lower health care costs. In 2022, the U.S. spent a little under 5% when looking at all payer types on primary care specifically. And chronic underinvestment by the healthcare system has left the U.S. primary care in a position where we're increasingly unable to meet patients' needs, particularly in rural and underserved communities. And the lack of funding for primary care specifically leads to administrative burdens for primary care providers, which has diminished the primary care workforce, and it's also reduced access to preventative health care throughout the nation. So the big question is, what can states do to improve primary care access? And I think it's a large question and something I don't think I'm equipped to answer, but I did do some research on what some mechanisms and some levers that states have pulled to improve primary care access. Wanted to note that currently 22 states are reporting on primary care spending in their state. So some states have defined and measured the amount of money that is being spent on primary care across different payer types. And then some of those, not all, have also set spending targets to basically say out of all of our healthcare expenditures, we want this percentage to be spent on primary care specifically. And so additionally, in addition to setting a primary care spending target, other states have focused efforts to produce more primary care clinicians, such as physicians, PAs, and APRNs, and also looked at increasing utilization and coordination by implementing alternative payment models in Medicaid and other payer types. Also focusing on ways to reduce the administrative burden, which, as you know, can be burdensome, obviously, on providers and reduce to burnout and having also, just the primary care burnout and some of the mechanisms that they're required to follow. It reduces often certain physician or medical students from seeking occupations in primary care. Primary care also pays a lot less than some of the other specialty areas that physicians can go to school for. So that's also resulted in a reduction in the primary care workforce throughout the state and the nation. And just wanted to highlight that a quarter of Nevadans, so about 25% of Nevadans, they lack a usual source of care. So primary care is definitely lacking in the state. Did want to note related to the primary care spending target, just as an example, the state of Washington back in 2021, they passed a law that set a goal for the state to spend, to work towards getting to 12% of all healthcare expenditures to be spent on primary care services. So they did that. They also created a Washington Advisory Committee on Primary Care, which that primary care committee worked to develop a primary care definition that outlines individual codes for different claims-based expenses and non-claims-based expenses. And the non-claims-based expenses definition included primary care payments from carriers to providers that may not appear on the claim. So really this committee worked to create a definition to then identify, okay, what do we want to consider to be primary care expenses? And then now that we have this definition, we can really measure what our state is allocating towards primary care. So in thinking about this primary care subcommittee of the PPC in Nevada, this is not a comprehensive list, and really this is just a draft, but here are some key focus areas this subcommittee could work towards. One could be establishing a state definition of primary care similar to other states like Washington, to include claims-based and non-claims-based definitions. Once we had this, definition, we could then discuss and consider if we wanted to work towards a spending target of any means. But in addition to that, they could review available data and conduct and evaluate the current amount spent on primary care in Nevada. Additionally, identify state policies for primary care payment reform and investment, and determine the adequacy of primary care delivery and the effects on the primary care providers in the state. And then, as we've discussed a lot, looking at ways to expand GME training opportunities, but specifically for primary care, really looking at how do we increase the number of community-based primary care practice settings to really expose these medical residents to primary care opportunities when they're still in school. So this is also just obviously for your consideration today in looking at the Washington model and other states who have created committees to really focus on primary care spending and just ways to increase primary care access generally. These are some this is a membership for your all consideration discussion today. I have shared this with each of you, most of you individually as well, just to receive initial feedback. But we are proposing that the PPC create this primary care subcommittee with about 15 voting members. At least 20% of those, so about 3 members would be voting members from the larger PPC. And then among those 15 member slots, these are the different types of positions. So we have, various provider types with experience in primary care settings. We have patient and provider advocacy groups, commercial and private payers of healthcare, state regulators of healthcare insurance, including Medicaid, and representation from the Division of Insurance, and other representation from rural health and a graduate medical education representative as well. So happy to, discuss this before you, address any questions that you have related to creating this subcommittee. If once discussion is over, this is a draft motion if you all wanted to pursue this, really asking if the PPC wishes to form this subcommittee and ask them to focus on reviewing issues related to primary care access on your behalf. And so with that, Chair, I'll go ahead and stop talking, open it up for discussion today, and happy to hopefully address any questions that you all may have.
So if I may sort of give the initial comment, it's a pretty significant sized committee, as you understand, as a whole. So what I would suggest is if the members think this through over the next maybe no more than 2 weeks so that we get going, their interest in this committee as commissioners. And Joseph, perhaps you could solicit from the other this organizations that you have mentioned in this, to look for representatives from those entities, so that before our next meeting, we have some structure to talk about it. And each commissioner has also had an opportunity to think this through. And the other thing, Joseph, I think for the commissioner's benefit would help, is to understand the time commitment. I would suggest a chair for a subcommittee so somebody can direct that committee meetings and, chairing that committee with some structure, and then come back with a prescribed time with recommendations down the road. So I'll open up for discussion.
Thank you. And before we open it up for other members, just wanted to reply to your comments, Dr. Khan, Joseph Flupi for the record. So the plan would be, if you all were to approve creating this subcommittee, we would then, we've already started drafting an application process. It would be electronic, so really open up to the public, anyone interested in applying for these different positions. Of course, I would coordinate with the various agencies or organizations that are specifically listed here, to see if they have anyone identified who would like to apply. And then, yes, I agree that we would need to help appoint a chair to help lead these subcommittees. And as far as time commitment goes, I think we're still working through that. I was envisioning these committees to meet initially probably monthly, once a month, to start this work. And then, of course, we would be able to give you updates between, the different larger PPC meetings on the progress that these subcommittees are doing. But with that, I'll hand it back over. Marilyn, you have your hand raised.
I do, and I realize it's a big committee, but I think you're missing a couple of key folks. So the Public Employees Benefit Program, that's specific to state employees, but where are the self-funded trust funds? I mean, because they're trying to push primary care, and where's an educator because we really need to talk about, here's what I see as a problem in Clark County in particular. Everybody is not going to a primary care doctor. They don't even typically have a primary care doctor, because they've never seen that. They rely on the urgent cares, the EDs, the emergency rooms for their primary care. So I feel like there has to be, and maybe it falls under Mr. Kipper, is somebody that can help market the difference, because a lot of people don't know. But I mean, for self-funded trust funds in Clark County alone, it's over 175,000 people that are self-funded, and they're not the same as commercial insurance. It's a little bit different. That's like all the hotels, and I mean, it's a big group it's a representation that's being left out, I think. I'm just curious, how would you fit them in?
Mr. Kipper might be better to speak to this than I. I believe we left them out, not to say that they wouldn't be able to weigh in and give input on any of this. And so you bring up a good point, but I believe as far as the state's oversight, the self-funded plans, Mr. Kipper, are they responsible to follow state regulations, or are they exempt from that? Or Adam Plain, go ahead. Sorry, I didn't see your hand was raised. Okay, not hearing anyone from the Division of Insurance. So it's my understanding that the ERISA plans and the self-funded plans, they are not responsible. I'm probably not framing this the right way, but really
you're correct. They
Okay.
don't have to comply. You're correct. But at the same time, we're talking about primary care, period, right? So at the end of the day, even those people, they still got to have access to doctors and all of those things. So, all right. I want to make sure that we don't leave out 200,000 people, because primary care is good for everybody. And so
that's a good point, Marilyn. You bring up a good point. So happy to include a membership from one of those organizations, just to provide, like you said, feedback on how to improve primary care access, statewide. So thanks for that input. And Adam, I think you have your hand raised. Please go ahead.
I do. Adam Porth for the record. I also would like to suggest another committee member, and maybe I can serve in that function. We utilize pharmacists for patient co-management in primary care at Renown up in the north. We've done a lot of work through the legislative process to try and create mechanisms to expand collaborative practice to address not only patient access issues, but physician burnout, to have pharmacists as a member of the chronic care team. And so I'm wondering if, within this, we just want to consider that as a possible part of the care model in the future. And so, I can serve from that perspective, or we can have another pharmacist, I think.
Thanks, Dr. Porth. Yeah, happy to add a pharmacist position to this membership as well.
Any other comments?
He,
Useful suggestions in terms of the committee structure. So any other comments before we go to the next item?
Marilyn, you sound like you wanted to say something, and then we'll go to Walter.
Sorry, I thought I'd seen Walter's hand come up, but I'm just wondering, do you think actually this subcommittee could be into two subcommittees? Because I could see what happens, right? There's different pieces of it, right? Which could get caught up in the longer conversation. And then we might lose track of the other. So maybe at some point we can, pare it down to 8 people or 9 people, and then have another subcommittee that maybe focuses on the insurance component, the pharmacy component, all of those things, so that we got to educate people at some point. So I just food for thought. Maybe it's hard to get anybody. I would hate to see a committee where one person does all the talking and no one else gives any input, because then we didn't really gain anything.
And this is Joseph for the record. I'll just say that will be a priority of mine, Marilyn. I think the goal of any committee really, but especially these subcommittees the reason that we're trying to be be thoughtful about creating the different members to serve on this. We want feedback and input from all of these various stakeholders. So definitely if it ever seemed that one stakeholder, I guess, for lack of better words, was stealing the show or whatnot, we'll definitely just seek additional input from other members and voices as well. Agree that we want all different stakeholder feedback when forming these. Mr. Davis, go ahead.
Well, thank you, Commissioner Davis, for the record. I just looking at the mid-level provider is one recommendation. Then it have on there it's the same as the provider and the social worker. Is that like a behavioral health individual that we're thinking about recommending to this committee? Are they the same?
This is Joseph for the record. I think definitely a social worker would have potentially that behavioral health component. Really, I think for that position, we were thinking more of the healthcare coordinator role, which I know social workers can serve as. But really, I think to Marilyn's piece too, as far as educating the patient related to the primary care options and just the coordination of the care between the patient and the provider, we were looking more for that role.
Okay, I would recommend that we have a behavioral health individual in this as well too, as a part of that whole collaborative coordination. I definitely agree with the pharmacy component as well too. And my last question is, if this is adopted today, what is the application process? Is it online, or how will we get that information?
This is Joseph for the record. Yes, so once this is approved, we would take all the feedback provided today related to the membership. We've already started an online application process, so it's just going to be an electronic form that's sent out via email. We can also likely post a link to it on our website. I will be sure to send that to all of you as members for your consideration to one, apply, but also for your consideration if you'd like to forward it on to any individual that you think would be a good fit. And so, that would be the goal to do within the next couple of weeks, is to get that application out, posted publicly, to then have people start applying for these positions.
Thank you. Any other comments? Do you see anybody or hear anybody, Joseph?
No, I do not, Dr. Khan.
Okay, so we need to sort of put this all together. I believe we need a motion to create the subcommittee. And the input that was given, if everybody agrees to incorporate that. Does
Motion.
anybody have concerns about incorporating today's suggestions?
Joseph, can I ask a quick question? Yeah, I was going to say, so are we open to having two subcommittees? Because I know you're going to do a presentation about another one next. So I just wanted to make sure that I understand like the PPC so we can support two subcommittees. Okay.
Correct. Yep.
Because
So
I know
this
they
is
tie
one of,
together very well because it's women's health, which is also primary
Yes.
care. So I'm going to
right.
say, I know
So this
that-
is one of, thank you. This is one of two being proposed today before you. Yes.
Okay, thank you.
So are we ready for a motion then? To approve?
I will move to approve. This
Is
is
there a
Flo
Yeah,
Khan.
I can second that. This is Andrea.
Great. Any opposed? None, motion carries, and we'll look forward to this final list. Joseph, as soon as you put it all together, obviously you'll share it with us, and then
Yes.
we can go forward. My personal opinion, and I shared this with Joseph, is I don't think it's appropriate for me as a chair to appoint a chair of the subcommittee. The subcommittee perhaps should pick a person who is actually a formal member of this commission as the chair to conduct the affairs. That would be my recommendation, that in the first meeting, whenever that takes place, the group should collectively choose a chairperson to conduct the meetings of the subcommittee. Any other thoughts? If not, I think we are moving along, Joseph, to the next agenda item.
Dr. Khan, we're still, sorry, this is Joseph for record. We're still on the same agenda item. I just have one more subcommittee to propose to you today, and then we can move on to the last item.
Oh, okay. Yeah, I think I missed that one. Okay, go ahead.
Thank you. So second subcommittee for consideration today relates to women's health and reproductive care. Really quickly, you all know the need, but we rank among the lowest in relation to women's health and reproductive care in the state. Specifically within these metrics, we're 51st on healthcare quality and prevention, 49th on coverage, access, and affordability, and 39th on healthcare reproductive outcomes. There's many other statistics, but for sake of time, I'll just go ahead and move on. And related to what Nevada, recent actions in Nevada. So although we rank poorly in women's health and reproductive care, there is a commitment across the state to improve through recent legislative and policy actions. They are listed on this slide. For sake of time, I'm not going to go through every one here, but several bills have been passed related to increasing access for women's health, and other policy reforms have taken place. Specifically on the right-hand side, Medicaid is currently developing a value-based payment program targeting maternal and infant health specifically. So moving on from here, some opportunities for this Women's Health Subcommittee. As stated, Nevada ranks poorly. We also lack what's called a state-supported perinatal quality collaborative, or PQC. For those that don't know what that is, PQCs are state or multi-state networks of teams, and they work to improve the quality of care for mothers and babies. They work to identify healthcare access processes in need of improvement, and they suggest the best available methods to make changes as quickly as possible. And so one opportunity would be for this subcommittee to look at ways to create a state-supported perinatal quality collaborative. Why the PPC? You all are uniquely positioned to drive change through recommendations and other means. You have bill draft requests and can advance legislation, but also can extend further by convening cross-sector stakeholders and then turning data and recommendations into policy change. So this is just some examples of some possible key focus areas of this Women's Health Subcommittee, reviewing available data and evaluating issues related to women's health in the state, identify state policies for enhancing women's health and reproductive care, working to increase access to timely and adequate prenatal and postpartum care, and then identifying strategies to develop a state-supported perinatal quality collaborative. And just for background on that a little bit, the state did try to request funding for a state perinatal quality collaborative this last session. That was one of the measures that was not approved in the budget, just due to some budgetary concerns that the legislature was considering. They really didn't like creating brand new programs or increasing staffing if they really didn't have to. They were being really stringent on that this session. So looking at future opportunities for creating that PQC as was attempted this last session, and then also collaborating with Nevada Medicaid and providing feedback on their current value-based payment program that they're currently establishing as it relates to maternal and infant health. So again, before you is just a mock-up of possible membership for this committee. We were looking at about 14 voting members, with 2 of those at least being from the larger PPC. So as shown here, the membership consists of various providers who have experience providing healthcare services to women. The membership also includes representation from state, tribal, and community-based programs, as well as consumers. So I won't read each of these individually, but are there any comments or questions related to this membership list? Andrea, please go ahead.
I would just kind of add on to this. I know that there's a strong emphasis in behavioral health, and the outcomes from Nevada's Maternal Mortality Review Committee actually show the #1 cause of pregnancy-associated death is overdose. And so I think that this ties, in very well with the interests around addressing behavioral health, because I'm sure that will be a strong part of these conversations. And then would just tie in that, women's health is considered to be primary care. And so I think where the PPC, is taking a strong emphasis with that other committee, I think that this ties in nicely to that in addressing women's health. So we just kind of add those 2 pieces.
Thanks, Andrea.
Any other comments? I have a comment in anticipation of our meeting today on this subject. Personally, I think we talk a lot about women's health, and rightly so. However, sadly, we are not, as a state, willing to put our money where our mouth is to make sure this happens. There's always this opinion about, well, the state doesn't have enough money, there are so many other things, etc., etc. The way I look at it is, unfortunately, to begin with, healthcare services, as much as we talk about it, are not the biggest area of discussion, debate. I mean, I've been on committees and commissions before on healthcare access, etc., over the last 20 years. This subject has been discussed in every committee or commission, and then some. But as you saw in this data, what progress have we made? We may make our recommendation, sincerely devote time and effort and energy in putting things together, getting the right people to make the recommendations. When it gets to the state legislature, etc., it all gets hogwashed one way or the other, and maybe a few cents are thrown at it, and that's it. I really am concerned that we are not having a total commitment as a state towards healthcare as a whole. As you see the numbers, we are 49, 48, almost 50th in some cases in healthcare and various sectors. I think it's time the state takes this seriously. I understand we don't control the legislature, etc., but whatever opinions or recommendations we make, we have to put some of our weight behind this. I know we cannot lobby the legislature once the BDRs are submitted directly, but just this is some food for thought. I'm just venting out. I was talking to some physicians the other day. You have these neonatal born 1 pound, 2 pound, 3 pound babies that are in the hospital for months and months and months. They survive. But our state services have limited financial support, period. The doctors are committed to their care. The family is struggling. We are just not committed to looking at as a global situation. And it's not like one child or two child. You go to any hospital, neonatal intensive care unit, there are dozens of children in that category. The surgeons, the kids being born with congenital issues that need surgery. The pediatric surgeons are in shortage in the state, like everything else. These are more shortage than others. They are not reimbursed adequately either, yet for a baby, they have to be there 24/7 available for these newborn babies with problems. So it's a bigger challenge. I feel frustrated that decades have passed. We haven't moved the needle. And the people don't come. We have already talked that in the physician shortage issue for many meetings. But I think for the next meeting, just food for thought. I know Commissioner Kilpatrick is here. She is very well informed, being on the UMC board also, of all these challenges. But others, I would really urge you to look at creative ideas and thoughts that we can come up with, where these providers are struggling to do their work, and the state keeps cutting and cutting and cutting. And it's along when the state cuts, the managed care organizations, the commercial sector cuts their reimbursement and services also, or uncovered services, on and on and on. That's for another day. But the thing we are talking about now on women's health, to me, is very near and dear that we haven't moved the needle. So I'll stop there and let the commissioners speak.
Marilyn, please go ahead.
Thank you. And Dr. Khan, you're not wrong. I was in the legislature when we fought to get ovarian cancer checkups, covered in insurance as a whole. But I have a suggestion. I heard a lot this legislative session how legislators felt left out of all these subcommittees, and I said, hey, not for nothing. You could create your own dang subcommittee, but we can't. What if we do a conscious effort to send at least the chairs of health, and I think we can do this as a board. Hey, you just wanted to put on your radar all these meeting notices that are going out of things, just so that they have a copy of the agendas on women's health in particular. There's a female majority, but I don't know that there's a lot of champions on things that are not one-offs. I mean, we need a champion on it for all of women's health, but all of primary care. So I just think that maybe if there's an opportunity to just send them the notices of when these committees are meeting, then they could do something with it, and then we could ask to go before interim health in October to kind of give them some updates, so we could say it out loud. We have these subcommittees, we're doing all these things. Then it's just a different scenario to hear how they wish they would have been invited to be part of these committees. I said, well, I wish you would have created them so I didn't have to sit on them, but maybe there's a balance here to do both.
Yeah, I agree with you, Marilyn. this thought of a champion, I strongly agree with that, because you need a champion in the Assembly and the Senate. And the champion really has to be committed from the heart and soul. Only then maybe the needle will move in next 2 years or whatever it takes. I need some input from other commissioners also.
Flo Khan, and then Jalen, go ahead.
Thank you. FloCon for the record. I was thinking about for the committee membership, could we add someone that's doing research and development in the women's health space? I think it's always helpful to kind of see what's coming down the pipeline and road of what's being researched and potentially developed that could be helpful in future, but also, you know, could provide some cost savings along the way.
This is
Thank
Joseph.
you.
I'll take that feedback and see what, yeah, I agree that it would be helpful to have a representation like that. Just trying to think through if that would be, you know, reaching out to maybe one of our state universities, seeing if they have someone identified, but yeah, happy to add that
Yeah.
additional.
I see Dr. Hyman's hand up.
Go ahead.
Thank you so much. I agree with you. I mean, I think if you look at the numbers, they've been abysmal over the last few years, and no matter how much money we throw at these issues, I agree with Dr. Khan and Joseph about where we're at with this. I think a lot of these issues do come down to money. I'm one of the providers who does craniofacial surgery in this community for the past 20 to 30 years. And if you look at the reimbursements, it's actually gone down in terms of doing these types of procedures. So in terms of we can have all these committees and all of these issues and come up with these grandiose ideas, but a lot of the issues come down to how do we keep providers here to do this? And I think you raise a good point, Dr. Khan. There's almost no pediatric surgeons, and I know they're rare around the world because of the training pattern, but we just lost another great one here. And, you know, trying to keep people here with the reimbursement, and, you know, I'm not blaming anybody because it's expensive to take care of people, but if you look at the numbers and the numbers specifically, our reimbursement for Medicaid and Medicare is among the lowest in the whole country. So if you're trying to attract people to come here, you can't get people of quality or get numbers of people to give the providers with the level of reimbursement. And if you look at a procedure that's done in Nevada, the same procedure done in California and New York is paid at 5 times the rate through Medicare, and then commercial insurance follows Medicare, and Medicaid follows, to some extent, Medicare. So that's something that needs to be done on a legislative level, and that's how you increase the person power of people to stay here in this state. And I'm fortunate because we can amortize in our office the ability to take care of people at limited who are of need and do a lot of free services in our office because we get, on the other hand, get some stuff done through cash. But it's difficult to do that for a lot of providers who are just, you know, either working at facilities or, you know, working at the university system, et cetera. So I think it's a good start. Women's health is a critical need here, and it's a critical need to provide for the underserved community, and it's also critical in terms of the primary care. But I think the issue globally is, and I think you're right, we need to get some of these legislators on these committees. And I think that if we can get some of them in terms of interest on the Women's Health Committee, or at least invite them to be there and know about these committees and give their input, maybe that will influence them in the next legislative session to see if there's some solutions, because if we can make them part of the solution from the beginning, then they'll feel included down the road when legislation is actually going to be passed.
This is Joseph. And before we go on to Jalen, just wanted to reply to some of the comments. I agree that including legislators, whether it's just through, you know, updating them related to our meeting notices, you know, happy to add them to our listserv and just spread awareness of our upcoming meetings. I know that also in the maternal health space, I believe there's a state maternal health advisory board, and I believe on that board there's a legislator that sits on the board. And per statute they have to add a legislator on there. So I can do some research to see who that legislator currently is, and maybe, you know, definitely include them in this women's health subcommittee discussion and invite, but also just sharing it more broadly with other lawmakers as well in case they have interest. Jalen, please go ahead.
All right, Jillian Behanan, for the record, I apologize. I joined after roll call. I love the discussion. I love the idea of these subcommittees, but when I look at the key focus areas and hear about all of the issues, it may seem overwhelming. There's a lot of issues. So would it be the intent of the subcommittee to maybe narrow it down to the 1 or 2 objectives to try to move the needle? And we're not going to be able to solve all of the issues. So will it be up to the subcommittee to decide where we could actually make an impact?
So if I may answer that, that's a very good point. My personal thought would be when this committee meets, you can prioritize from the list that is being discussed right now.
Hello.
Can you hear me?
Good. How are you?
All right. So you can prioritize which 2 or 3 or whatever subjects that you think.
I'm actually on a meeting right now, so I can't come downstairs.
Does that make sense?
Yes. Thank you for explaining that.
Yeah, I think if the committee, I would like to see the committees be as autonomous in making their recommendations or suggestions or running them their own system. So perhaps it can be prioritized based on what you're saying by the committee.
Sounds great. Thank you.
Any other thoughts? Anybody else? So Joseph, you've got enough work to do or no?
Thanks, Dr. Khan. This is Joseph. Yes, plenty of work to do, but it's important work. So before we move on, there's a motion before you. Would just need you all to approve us creating this Women's Health Subcommittee to include the additional recommendations as discussed today.
Do I have a motion for that?
Motion.
I believe that Dr. Glyman motioned.
I can second that. Oh, there you go.
Any opposed? If none, the motion carries. Thank you very much, all the commissioners and other non-voting members for the input. It'll this takes us to our next item.
Hey, Dr. Khan?
Did I miss anything?
Just before we move on to the next item, I just wanted to remind everyone that the last item that was agendized, it was great, the actions that we took, and I totally appreciate all the work that Joseph put into that. If any of the members of this commission think that there are other subcommittees that they want to, enlist in the future, that's certainly possible. I mean, it's possible to do that now, but I think that there hasn't been specific research that Joseph's done on it. Or you could reach out to Joseph directly or to Dr. Khan and suggest a possible subcommittee that this commission could then recommend and take action on. Thanks.
Yeah, I agree with that. The commission is always open to suggestions, and Joseph always passes on to the whole team to get their thought, and it gets on the agenda the next time and gets worked on. So that's a very helpful reminder. All right, Joseph, going to the next item number 8 for review and approve semi-annual PPC report required per NRS 439.918. Go ahead, Joseph.
Thanks, Dr. Khan. Joseph Filippi for the record. This item is for possible action, and as Dr. Khan mentioned, so according to statute NRS 439, the PPC must submit a semi-annual report. So every 6 months, we must report related to the meetings and activities of the commission during the immediately preceding 6 months. The report must include, without limitation, a description of any issues identified as negatively impacting the quality, accessibility, and affordability of healthcare in the state, and also include recommendations for legislation, regulations, or other changes to policy or budgets to address those issues. I did submit a draft report that was distributed to all of you ahead of today's meeting. It's also been posted publicly as an attachment on our website today. Chair Khan will now open it up for any questions you or the commissioners may have. If I need to pull up the document at all and share it, I'm happy to do that as well, but just happy to address any questions you have.
Thank you, Joseph. Go ahead. Any questions from anyone? You see any, Joseph, that I don't see?
No, I do not, Dr. Khan.
Okay. So do we need to do any action on this? There's no new comments or suggestions.
I believe the motion would just need to be you approve the draft report as written and approve for submission.
So I'll open it for the motion and then a second. Do we have a motion?
I'll make a motion to approve. This is Commissioner Buchanan for the record.
My second, Commissioner Davis, second.
Thank you. Any opposed? If not, then the motion carries. Thank you very much. Let's see, our next item, Joseph, is a public comment. Go ahead.
Perfect. And before we get there, just wanted to quickly just highlight our next meeting schedule. So following today's meeting, going to submit the report you all just approved on by the 1st of July when it's due. We are then meeting next on August 15th, which is a Friday. That's going to be our next larger PPC meeting, and that's shown here around September or so is when I'm thinking we'll have hopefully the subcommittee members appointed, and hopefully they can start meeting monthly. Like I mentioned earlier, me and the team will be working on submitting that application or releasing that application process publicly following today's meeting. And we'll have an update for you hopefully by our next meeting in August related to the formation of the subcommittees that you approved today. So with that quick update, we'll move to public comment today. Again, if you are calling by phone, if you're joining the meeting by phone, just press *5 to raise your hand. If you're joining by computer, you can raise your hand through the Teams platform. Anybody wishing to make public comment to the Patient Protection Commission this morning? All right, seeing no hands raised, Dr. Khan.
Thank you very much. So before we adjourn, any commissioner wants to make any comment, just open on any subject? We have a couple of minutes because this has been the shortest meeting of my lifetime on any commissioner board. So any other suggestion or thought? If not now, please feel free to share with Joseph. We want to broaden the input from the commissioners as much as possible. Hearing none, right? Then we'll move to adjourn. Thank you very much, everyone. We made a lot of progress today. And Joseph, in particular, thank you for staying on top of everything and teaching us.
Thank you.
Thank you all for your time.
Thank you.
Have a good weekend.
Thank you very much.